Good afternoon, everyone. We welcome you to the Bay State Health Heart and Vascular Lecture Series. My name is Patrick Schilling, and I am the manager of cardiovascular rehab here at Bay State Medical Center in Springfield, Massachusetts. We are so happy that you're able to join us today. This presentation is being recorded for those who are unable to attend today, or if you would like to view this presentation again in the future. All recordings can be found on the baystatehealth.org website. You can also register for the upcoming lecture in the same area on the baystatehealth.org website. We welcome questions you may have regarding this material and will address them at the end of the presentation. You can type questions in the Q&A area located at the bottom of your screen, and we simply ask that you keep your questions pertinent to the topic today. Finally, you will have an opportunity to provide comments and feedback about today's presentation immediately following the Zoom presentation. And at this time, I'd like to introduce today's presenter. Dr. Hazel Marecki is the newest addition to Bay State Vascular Surgery team. She is a Massachusetts native through and through, growing up in Arlington and completing undergrad at MIT, where she double majored in mechanical engineering and biology with a minor in music. Before studying medicine, she was a circus aerialist in Circus Schmirkus and an All-American heptathlete and pole vaulter in track and field. She moved west and completed medical school in an integrated vascular residency at UMass in Worcester, where she developed interest in limb salvage and complex endovascular aortic aneurysm repair. She then moved west again and joined Bay State in July 2022 and delivered her second child, a daughter, in September. Her now family of four resides in Wilbraham, and she is so happy to be part of the Bay State Health team. Welcome, Dr. Marecki. We are happy you could join us today to talk about the latest advancement in vascular care and vascular surgery.
Hi, good morning or almost afternoon, everyone. I'm Hazel Marecki. Thank you for that kind introduction. I am at Bay State Vascular Services in 3500 in Springfield. And this morning we're going to be talking a little bit about pain in my legs. Do I need to talk to a vascular doctor? So, full disclosure, I let the presenters choose my title, and here's why I love it. It captures the nature of why vascular surgery is commonly misunderstood, or why people don't really understand what vascular surgery is. Not just patients, fellow physicians, it's sort of well documented. And that's because what we do is sort of all over the body, and it's very varied. It also captures the anxiety about having a symptom, which could be vascular, and being referred to a vascular surgeon. And then lastly, it captures the confusion of, is my problem vascular, and is it a vascular doctor or a vascular surgeon? And so I wanted to just start out just a little bit. What is vascular surgery and what do we take care of? And so this is a cartoon I created called Vascular Man. And so Vascular Man is going to teach us just very quickly what it is that a vascular surgeon treats. So in the neck, we treat the carotid arteries. These are related to the stroke risk and a risk of a mini stroke or transient ischemic attack. In addition, sometimes help in the resection of tumors. In the upper extremities, we manage dialysis access, traumatic injuries to the upper extremities, and arterial blockages. In the chest, we treat aneurysms and dissections and traumatic injuries. In the abdomen, we treat blockages in the mesenteric arteries, blockages in the renal arteries, blockages that in the bigger arteries, the aortoiliac system, also aneurysms and blockages in the venous system, May-Thurner's disease. In the lower extremities, there's peripheral arterial disease, where we'll spend most of what we're talking about today, where we can result in symptoms of pain with walking, pain at rest, and then the most severe pain with ulceration. And then we additionally treat aneurysms of the lower extremities, traumatic injuries, and chronic venous insufficiency with varicose veins and ulcerations. So do your legs hurt when you walk? There are several causes for vascular lower extremity pain. Uh, the first and most commonly one that we think about and treat is peripheral arterial disease. And so this is blockages that happen somewhere between where the blood comes out of the heart and where it gets to in the very tips of the toes. And so any blockage in those arteries can result in either claudication, rest pain, or ulceration. And we'll kind of talk a little bit about each of those. And then additionally, we treat chronic venous insufficiency, which is also a cause of lower extremity pain, with superficial venous insufficiency with varicose veins, can cause swelling or edema, and deep venous thrombosis, or blood clots. So peripheral arterial disease. This is another way of describing this is atherosclerosis of the lower extremity arteries. And so the anatomy is that that those blockages can occur and do commonly occur in the aortoiliac segment, in the abdomen, in the femoral-popliteal segment, in the thigh, in the tibial segment below the knee, or within the foot itself, called intrinsic foot disease. Vasculogenic claudication is pain that comes on with walking or ambulation. So generally people will describe that they have no pain that when they're sitting down, no pain when they're sort of lying in bed, but that when they start to walk, I get about a block or maybe 2 blocks, and I start to get this aching in my calves. And we've all sort of had that feeling, when we start to walk up a mountain or something and we haven't, maybe done it in a while. And you felt, my muscles are tired. I feel like I want to rest. And so claudication is sort of a more severe and earlier onset of that same type of symptom. And it's really bothersome. People will actually stop walking. So it's the type of thing that, I just can't walk anymore. I have to rest. When I rest, my symptoms go completely away. And when I start walking again, that's when the symptoms come back. And it's normally that they can walk about the same distance that they could walk the first time, and until the symptoms come on again. And so that's the most classic description of vasculogenic claudication due to peripheral arterial disease or due to blockages in the arteries. And it's really the first sign of low arterial blood flow to the legs. So why does this happen? It happens when the metabolic demand of the muscles of the legs is greater than the supply of blood that the body can provide. So normal healthy arteries dilate in response to exercise and can actually give more blood flow to the legs. But calcified arteries, or arteries that have severe blockages in them, can't respond that way, can't get more blood through a very tight space, or can't relax to let more blood flow down to the legs with exercise. And so additionally, those very diseased arteries that actually can physically have complete blockages, your body is trying as hard as it can to get other pathways around those blockages and get blood flow down to the legs. But the body just can't react to the greater demand of having to walk and all the blood supply that the muscles are asking for. And so people describe that this is squeezing, tightness, or crampy feeling and generally they'll describe it in their calves, because in order to kind of get these symptoms, the blockage has to actually be above where the muscles are. So the arteries in the thigh sort of are the ones that supply the area below the knee or the calves. And so the calf muscles are the ones that are most likely to kind of get that feeling. Occasionally, if people have disease in their abdomen, in the aortoiliac segment, they may feel claudication symptoms additionally in their thigh or in their buttocks. And as I mentioned, this is an annoying enough pain when it happens that it forces people to stop and rest. and it generally resolves with rest, and then it's reproducible. That you can walk that distance, and then it happens again, the same type of pain, the same distance. And so people describe that as worse if they're going upstairs or hills, because that kind of requires more muscle work. And we really try and describe that this is, when we characterize this as this is vasculogenic claudication, is that this is something that limits the activities of daily living. And so who gets peripheral arterial disease? Who gets vasculogenic claudication? This is a disease of aging. So I'll, get grandparents that say they can't keep up with their grandkids. People that, I've, worked my whole life being able to, walk my male route, but now I just can't really get as far as I used to be able to. Or every day I used to walk on the track or walk my 5 miles, and I can't walk as well as I used to. I have to rest. The classic risk factors that affect peripheral arterial disease are the same ones that cause people to have heart attacks. And that's because it is atherosclerosis. So we think about hypertension, and that's often treated with antihypertensive medications. We're now kind of recommending everybody, and then think that there's a talk in a couple of weeks about some blood pressure control. So we're trying to maintain everybody with a blood pressure of less than 120/80 millimeters of mercury. And as you can imagine, the blood is actually a column of fluid. And so you think about how much pressure there is at the bottom of a pool. There's a lot of pressure at the bottom of the legs. And so you're more likely to develop these blockages in your legs than you are in your heart or in other places, because the pressure is just so high in those arteries. It's more commonly, therefore, a disease of the lower extremities versus the upper extremities. People can get blockages in the upper extremities, due to kind of turbulence and some other factors we'll talk about. But most of this disease is happening in the lower extremities, where you're seeing these high blood pressures. A second risk factor that we think about for the development of peripheral arterial disease is hyperlipidemia. So high cholesterol, and particularly related to the low density lipoproteins. And another way of measuring sort of the total inflammation related to the lipids in our blood is a C-reactive protein. And we'll touch briefly on the biology of this. Other risk factors are diabetes. We try and keep people's A1C less than 7. And most importantly is smoking. Smoking is the single most the most important risk factor that somebody can modify. So it is the most, of all of these things, genetics, hypertension, hyperlipidemia, diabetes, we can do what we can, but the most important thing that patients can really do is smoking cessation. And so this is often a disease that travels with smoking. So atherosclerosis, just for the nerds and all of us, this is a word that comes from the Greek athero, meaning gruel, and sclerosis, meaning hard. And I think that just gives people an image of what do these plaques actually look like and feel like. The blood vessels are, consist of 3 layers: the intima, the media, and the adventitia. And as you can see, this is just some finer details about the cells that live in all of those areas. And the first type of atherosclerosis we see is a fatty streak. It's something that would be visible to the eye, and it starts in childhood. They've actually, from autopsy studies, we know that most people start to have atherosclerosis really in their 30s. It's benign, but it's the precursor that leads to later lesions that can cause problems. And the gist is that cholesterol and cholesterol ester filled cells called macrophages or foam cells fill in the layers of the blood vessel wall, and they hang out there. And the more inflammation that they cause, the worse problems that they can cause. And so we talk about sort of stable plaques with a thick fibrous cap and a solid lipid core versus an unstable plaque, something with a thinner cap. And those are the ones that can really cause a lot of inflammation when they rupture and can cause acute blockages in the leg, which can be very problematic. And so plaques do not progress uniformly. They do progress slowly. And so that's why this is a disease of aging, but not all plaques progress at the same rate. And you can see as they start to sort of fill up the blood vessel lumen, you can get an unstable plaque and you can, completely fill an artery. And then you can heal a ruptured plaque with a much, much smaller lumen. So just because something happens suddenly doesn't mean it's necessarily not having to do with vascular disease. And if we have time, we can talk a little bit about what happens when people do acutely block off their legs. Other important finer details are sort of that these blockages tend to happen at areas where there's turbulence in the blood flow because there's shear stress, and the shear stress of the blood against the blood vessel wall can really create a lot more inflammation and increase the cycles of inflammatory molecules that result in atherosclerosis. And then here's just a picture of these cells. And as you can see, the more inflammation they make, the more factors get made, and the more cells that die, and this plaque kind of builds up and becomes a worse plaque over time. And so then here's just one slide on the effects of the smoking, particularly on blood vessel plaques. The smoking increases platelets, it increases all of these same inflammatory markers, and it sort of decreases the amount of blood flow or nitrous oxide that these areas can see, and which is anti-inflammatory. And so this sort of results in an acute worsening of the process. And so it really does matter how much you smoke, and it really does matter whether somebody is a smoker in terms of how their blood vessels will behave. And diabetes in particular, we worry about that it's compounded with vascular disease because it puts people at risk for wounds and infections in their feet because they can't feel wounds as well. They're more prone to infections because of decreased inflammation, and then they have disease in the small blood vessels in the feet and below the knee that are related to diabetes. And so this triple threat really makes diabetic foot wounds a huge problem, and particularly troublesome with peripheral arterial disease. So how do we tell when somebody comes in and says they have leg pain? How do we tell whether or not it's due to the arteries? So there are a couple of different things that we like to sort of rule out that are common confounders of peripheral arterial disease in the legs. And so one of these is spinal stenosis. This can cause pain when a person walks as well. Generally, if the pain with walking is due to the nerves in the spinal canal sort of being pressed on, they describe the pain as radiating. Not always, but sometimes they'll describe it as radiating from the hip or from the back. And it's really a tricky one because it can totally present differently. Sometimes people do have calf pain that's related to spinal stenosis. But what I try and get people to tell me is, well, does this happen when you change position? Like, does it happen as soon as you stand up? because in that case, I don't really think that it's due to the blood flow, because your muscles haven't even started asking for more blood flow. It may be due to some nerve actually getting pinched, and so that makes me think more that if it happens right away and it happens with a position change, it might not be due to blood vessels. People can also have associated numbness or that comes on sooner with the spinal stenosis or the neurogenic claudication than it would come on with vascular. You have to have pretty advanced vascular disease to start having numbness of the feet. And then sometimes people will describe it switches from one side to another, or like sometimes it's just on one side or just on the other, versus generally vascular blockages are a little more consistent over time. Like if your right leg hurts you worse today with vascular disease, it's going to hurt you worse tomorrow. And then the last question is that we ask people is it better when you lean on a railing or with a walker or on a shopping cart? Because this type of positioning can sort of offload the nerves on the back and makes pain that's due to spinal stenosis better, but it doesn't make pain better that's due to the blood vessels. So because your muscles still need to, provide the work of walking and ask for the blood flow, whether or not you're leaning on a shopping cart or not. But if the shopping cart improves things, it's more likely that it's due to a narrowing of the spinal canal. Another thing that people worry about is, gee, my feet are really cold all the time, all of my toes, all of my fingers. And so this is more commonly due to a phenomenon called Raynaud's syndrome. And so this is sort of a spectrum of everybody's got a little bit of a different reaction to the cold. We try and keep the cold out and keep our own body temperature warm. And some people just have very reactive blood vessels that spasm down, especially in the fingers and the toes. And so this is what we call Raynaud's syndrome. It can cause a lot of the same symptoms and a lot of the same issues as low blood flow due to atherosclerosis. But this is generally more benign, and it's generally due to the small arteries that spasm. And it's generally people describe numbness a little sooner than they would otherwise with vascular pain. And they describe that their hands turn funny colors in like a grocery store aisle, or that after they go outside, on a cold day they notice that their feet take a really long time to warm up, and it's kind of painful, and they might turn funny colors as well. So generally, it responds to keeping the toes and the hands warm with wool socks, gloves, and occasionally. Very occasionally, Raynaud's syndrome can result in more dangerous phenomenon where the very tips of the toes actually do start to die or get what's called gangrene. And in severe cases, it can be treated with nitroglycerin paste, which is sort of a local paste that allows relaxation of these small blood vessels, or systemically a antihypertensive called a calcium channel blocker that works to relax blood vessels in the peripheral system as well. So amlodipine or nifedipine, and those are kind of given at whatever dose people can tolerate in order to relax the blood vessels. And then lastly, and we'll talk about it a little more if we have time, venous claudication. Venous claudication also sometimes is a confounder of arterial claudication. Generally, venous claudication isn't something that happens, with 2 blocks, but is something that happens after 8 hours on your feet, or 8 hours of being mostly on your feet, or your legs being down on the ground, and your legs get more swollen, kind of this aching, throbbing, non-specific. Sometimes people talk about pins and needles, and it's it doesn't tend to standing is just as bad as walking. So it doesn't have that clear association with walking where arterial claudication does. So what do we do when we think somebody might have peripheral arterial disease? How do we confirm it? How do we diagnose it? So these are some of the important non-invasive diagnostics that we use to diagnose peripheral arterial disease. The first is called an ankle brachial index. And I think it's really simple to understand, but it's still a little bit confusing. Like, why are people putting in a blood pressure cuff on my legs? So what it basically is it measures the blood pressure in the arms, and additionally measures the blood pressure in the legs. And it takes a ratio of the blood pressure at one ankle compared to the blood pressure in the arm. So it gives a percentage, as you can kind of think about it. It's the percentage of the blood flow that should be getting to the legs, how much is actually getting there. And we use the arms as well. The arms are close to the heart, not as likely to have blockages. That's kind of what we're comparing the blood flow to. So the finer points, they'll listen to two different arteries in each foot, and they'll take the higher of the two measures because it's sort of the best direct pathway for the blood to get to the foot, and they'll compare it to the higher of both arms' blood pressures as the highest amount of blood flow that your body could produce and the highest pressure. And so those two arteries are called the dorsalis pedis and the posterior tibial. And you can think of it as the percentage of the total blood flow. So we think about somebody who's got 90% of their blood flow. Maybe that's mild. That's pretty. They're still getting most of their blood flow, and not generally something that somebody would be symptomatic from. It's somewhere between 40 and 90% of their blood flow getting to their legs. People generally will describe claudication. Will describe that. I have some pain when I walk that I didn't used to have, or maybe it's worse on one leg than the other. And then below 40%, we start to think about more severe peripheral arterial disease that can cause pain at rest and pain that can produce ulcers and the inability to heal. Sometimes if all of the disease in the blood vessels is actually in the aortoiliac segment in the abdomen, it can be difficult to detect on the ankle brachial index. And that's just because your body is really good at making pathways. And so when you're not moving, you might have almost near normal blood flow to your legs. So if we really suspect that somebody's symptoms are related to blood flow and they tell us a good story, we might do something called exercise ABIs, where we do the same test, but we do it when the patient's at rest, and then we do it also when the patient walks for a certain distance and feels their symptoms. And then we do it again after they've rested. And so if there's a clear drop when they walk in the amount of blood flow that's able to get to the legs, so basically the arms are getting more blood flow when you're walking, and your arm blood pressure probably goes a little bit higher. Sometimes the legs can't relax and get that same amount of blood flow if there is disease in the pelvis. And so that can be a more powerful tool in detecting abnormal relaxation of blood vessels. And then there's also a non-invasive test called pulse volume recordings, where they'll actually put cuffs throughout the whole lower extremity, lining a couple on the thigh, a couple on the calves, and even on the toes. And this can give us an idea where it actually takes the volume of the leg and its response to each pulse of blood. And so we can create a waveform, and we know which waveforms are normal or abnormal. We can also read out numbers. And this tells us where the level of disease is. So if, the thighs should actually be getting, on average, a little bit higher pressure than we expect at the arms because of the column of fluid that's between the arms and the thighs. And so we expect them to be about 120% of the blood flow that we see at the arms. And if we don't see that, then we know that, oh geez, there must be some disease in the abdomen. And so that gives us an even better idea of where the blockages might be. still in a very non-invasive diagnostic way. And then if we need to get a little bit more anatomic detail, we have a nice test called a CT angiogram. And so this is a CAT scan. I'm sure many people have had CAT scans or known people that have CAT scans. But it gives a really good picture of the blood vessels because they inject dye into the vein and then they watch it travel all the way through the blood, the blood flow cycle until it's in the arteries, and then they watch it in the arteries. And so this is a special CAT scan that gives us a picture of the flow inside of the arteries. The pros are that it's still a non-invasive test where it's just an IV. You don't have to do a procedure in order to get this picture, and it gives really great resolution of anatomic data of blockages. So we can, see that, this looks like it's about 50% blocked off at this level, and it can give us a really good idea of where the blockages are. Some of the cons of this test is it does use ionizing radiation. So we don't like to, test people a whole bunch of different times with the same test because radiation does build up and cause risks over time. It does use contrast, and so some people, if they have some existing kidney injury, there can be at risk for kidney injury with contrast. And so that's why we'll generally ask people to get a blood test to check the kidney function prior to getting a CT angiogram. And then sometimes people have allergies to contrast. And then it also only tells us a snapshot in time. It gives us no data regarding the flow to the blood vessels. It's difficult to time the studies in order to visualize the really small vessels down below the knee. Sometimes we can get a decent idea, but it's not as reliable for the small vessel imaging. And it may overestimate the degree of calcification or stenosis because calcium just shows up so bright, as you can see in this picture here, where these calcium chunks are so bright. And then this is sort of the normal blood flow color. And so what do we do after we detect peripheral arteriosclerosis? A lot of times the first step is conservative management, especially if somebody's only presenting with the symptom of claudication or pain with walking. So as annoying as the symptoms may be, surgeries to fix blood vessels are often doomed to fail if we can't make the proper lifestyle modifications. And that, we're not, I love doing blood vessel surgery, but I'm not often as good as biology. And so what I create might not last as long as what nature creates in terms of, you can think of young, healthy vessels that are expected to last, 50, 60 years. We don't expect our repairs to last quite as well. And so unlike with more severe peripheral arterial disease, just having pain when you walk is not associated with a significant chance of limb loss over 5 years. And so that's that's why we know that it's safe to do conservative management, not to immediately get people better blood flow when they present with these symptoms. So in this sense, we are good vascular doctors where we have conservative management. We previously always recommended everybody to be on baby aspirin, but now it's sort of up in the air whether or not that makes a real difference in terms of an antiplatelet. We do recommend everybody to be on statin medications, or if they're unable to tolerate statins, a PCSK9 inhibitor. So the statin medications are things like Lipitor, atorvastatin, Crestor, rosuvastatin, and most importantly, these are the anti-lipid medications that we talked about in terms of hyperlipidemia. But even if you don't have hyperlipidemia, if you have these blood vessel blockages, we ask people to start on these medications because they're anti-inflammatory and they stabilize the plaques over time. And we actually know that people with blockages live longer because there's less chance of having heart attacks or strokes long term. So that's where we see our role kind of as a vascular doctor. Once we detect these blockages, we try to do our part to teach people about how do we go forward from here for healthy living and health and management of sort of the risk factors as well for vascular disease. The PCSK9 inhibitors are a newer drug. They're excellent. They're injectables and they work just like the statin medications, except they act a little bit further down the pathway and they don't have side effects. I think they'll be a lot more widely available in the future, but and at the moment they're kind of used only for people that don't have an adequate response or can't tolerate statins. And cilostazol is another drug that we can use. It's a blood vessel relaxer. It helps people increase their walking distance, but it's not safe in patients with heart failure. So it's sometimes used. People have some pretty bad symptoms, but aren't ready for a blood vessel surgery. And then lastly, of course, smoking cessation. And we recommend Chantix, nicotine replacement, and really persistence is the way that we see most people succeed who are able to succeed with smoking cessation. So wait, I thought this was vascular surgery, and so this is where we do have to do a significant amount of blood vessel surgery, but we like to make sure that we're doing it for all the right reasons, and all of the stuff that I just talked about comes first. When conservative management fails for peripheral arterial disease, we do have options to fix blockages and repair and replace blood vessels. First step is gathering anatomic data, either with the CT angiogram that we talked about or the invasive angiography, where similar to a coronary angiogram, we access arteries with needles and take pictures of the blood flow from the inside of blood vessels. So this is a minimally invasive procedure, and it gives us the best data to where the blockages are and how the blood is flowing. Additionally, at that same time, blockages can often be treated through minimally invasive surgery with balloon angioplasty, drug-coated balloon angioplasty, lithotripsy or atherectomy, and or stenting. So this is just a picture of an invasive angiography, and you can see that here we get a great picture of the tibial blood vessels. And we actually watch the dye in real time. So we also know how quickly it's getting from point A to point B. And like this blockage here looks really tight. Does it really sort of seem to block up the flow? And I imagine if I was clicking through this image and we were kind of watching the blood flow, that yes, a blockage this tight, I'd probably say is at least 80% blocked, maybe 90% blocked. And yes, it would truly impede the blood flow going from point A to point B. And so then we watch the blood flow go all the way down to the foot vessels and really see where the foot is being fed from. And so this gives us the best anatomic data as to where the blood vessel disease is. Balloon angioplasty modifies plaques by smushing the plaques against the vessel wall. I know it doesn't really sound that cool, but it is pretty cool. We do this in attempts to create a larger lumen or a larger pipe to send blood from point A to point B. So it increases the area of blood flow at a certain level, going from point A to point B. And so sometimes balloons are coated with medications to prevent blockages from recurring. And these are generally chemotherapy medications. And there's some debate in our literature whether or not it's worth kind of using these coated balloons. But here's a picture of balloon angioplasty. In order to use balloon angioplasty, you first have to get a wire that goes from the artery where it's healthy. So you can imagine the wires coming down the vessel from here to here. You have to get this. Here's the wire. You can barely see it here. That the wire has to get from the area with no blockage to the area below with no blockage. And we have to make sure that we're still in the blood vessel the whole way. So when we get the wire passed, we advance a catheter, and then we take a picture and we make sure that we're inside the blood vessel beyond it. And then we put the wire back, and then we deliver the balloon, where the balloon will be advanced right to the area that we want to treat, probably right here. And then we inflate the balloon for generally 2 minutes, allowing that plaque to really smash against the edge of the blood vessel wall. And then a lot of times we get a pretty decent looking result where the blood is certainly flowing much better. As you can see, it didn't make this into a brand new healthy blood vessel, but it certainly helped quite a bit. And there's a lot more blood flow going through this now. Sometimes the vessels don't respond as nearly that well to just a balloon angioplasty. So stents exist because they provide radial force to mechanically expand the lumen of the blood vessel and transmit the flow through the blood vessel. Additionally, if there's a small blood vessel tear called a dissection that happens in response to a balloon, the stent can make sure that teared tissue doesn't swing back and forth and cause more blockages in the blood vessels. So there are different types of stents. There are stents that are completely self-expanding, and these take turns really well and can form to complex shapes. And then there are stents that are balloon expandable, and these are really good because they have a lot of radial force. So for arteries like the iliac arteries that transmit a lot of blood flow in the pelvis, the balloon expandable and can have a lot of calcium. These balloon expandable stents are really good because they can push that calcium away. And then there are also stents that are covered versus uncovered. Generally, uncovered stents, they're just like a mesh that's going to press the tissue away. If there's any concern that there's sort of clot that needs to be trapped against the blood vessel wall, or that the vessel is so tightly blocked that it may actually rupture when we try to expand it with a balloon or a stent, then we might think about using what's called a covered stent. And so the covering can help protect against a break in a blood vessel. And there's some evidence that covered stents perform better in certain areas of high flow, and especially if they're sort of adjacent to less diseased areas. So we'll particularly use covered stents generally in the mesenteric arteries, in the iliac arteries, and then generally, mostly as we go down the leg, we'll tend to use uncovered self-expanding stents. And then I think small covered stents, because you can imagine it's sort of a longer tube and it's less like a native blood vessel. They are more likely to sort of clot off. So we try to only use the covering when we need to. And so then here's a picture of a stent placement. You can see here was a very tight narrowing in the blood vessel, and after the stent was placed, the blood was flowing much better. And then here, up in here is in this corner is just another picture of another type of stent called that they now have called a TAC. And so these are really, really small stents. This picture makes them look actually bigger than they are, but we're talking that they're on the order of less than half a centimeter. They're like about this big. And they're just meant to sort of oppose a blood vessel tear that happened in response to angioplasty, without sort of leaving a big stent or remnant that could cause inflammation and could cause blockages to get worse over time. So sort of leaving as little behind as possible to still get the best possible result in terms of blood vessel flow. And then a really important and new advancement in these sort of in minimally invasive peripheral endovascular therapies is called shockwave lithotripsy. And so this is using sonic waves to actually modify plaques. And so instead of using a higher pressure in the balloon, you inflate the balloon to just a smaller lower blood pressure, somewhere on the order of 2-4 atmospheres, and then you deliver this special sonic waves called shockwave lithotripsy, and this can help to break up calcified plaques, and especially calcified plaques that are too calcified to respond to stents or balloons alone. And so there are multiple devices that have sort of been created to try to modify plaques in this way. We have grinders and rotary devices, more that you'll sometimes hear referred to as atherectomy. But the reason I think that shockwave lithotripsy is such a powerful tool is because it's really not uncovering an area of tissue that is that could be more thrombogenic by like grinding out the layer that was in contact with the blood vessel wall. Instead, it's sort of modifying that whole plaque to thin out the calcium and make it respond better to your next therapies. So it's sort of considered a vessel prep, where you can use these balloons and use this shockwave lithotripsy to open up a blood vessel, and then additionally use a drug-coated balloon or a stent that you might be able to get away kind of with a self-expanding stent where you previously had to use a balloon expandable stent. And that can make a difference in sort of how long that your therapy lasts as well. And this is just a picture of, you can see some pretty severe blockages that were able to be treated with stents that were self-expanding, whereas normally you would have to use a balloon expandable stent in this area. And so what happens when peripheral arterial disease is more advanced? So as we said, a lot of times for just pain with walking, we don't even need to do therapy at all. So when are we doing these types of procedures? And then when do we actually have to do open surgery and we have to move out of the minimally invasive space? And so the other types of peripheral arterial disease, the more severe types beyond claudication, are grouped together into what's called chronic limb-threatening ischemia. And this is to just sort of remind everybody that this is, now we're treating somebody not because they couldn't walk as far as they wanted or because their life was limited, but now we're treating them because their limb is threatened, that they may progress to an amputation and lose their leg if we don't provide them with more blood flow. And so resting pain that happens just when you're lying down, is a sign of much more severe ischemia than the pain that happens with walking. And this is literally your body at rest is starving for blood flow, and generally happens in the forefoot. So people will describe kind of this aching pain. They don't really see a wound or anything else, but they'll say just right below my second toe or right in the ball of my foot, it just really hurts all the time, and it's this really nagging pain that I can't treat. I can't make it go away, and this is called rest pain. And it generally happens around 2 a.m. in the morning when the cardiac output is the lowest. So people say, I don't know why, it's at night. It's like I get this terrible pain, and then it's a little bit better if I dangle my foot over the edge of the bed. And so that is the other key point, is that gravity makes a difference. So if you really need that whole column of blood flow in order to get the blood flow to reach the edges of the toes, you can imagine that putting your leg down actually helps with this. It can get just a teeny bit more blood flow, and sometimes that's enough to get somebody out of the pain that they've been experiencing. And then the second subset of chronic lymphatic ischemia, or CLTI, is non-healing ulceration. So a ulcer that doesn't have enough blood flow to heal, and no wound can heal without what we refer to as inline blood flow. That is, sort of a connection between point A and point B. And we treat CLTI because without it, it can lead to amputation. So rest pain requires an increase in the amount of blood flow delivered versus an ulceration requires inline blood flow. And so oftentimes we can improve rest pain by treating a blockage, maybe not treating all of the blockages, but treating one very important blockage. And we try and do something that's in a large vessel, if we can, so that it has a lasting impact. Because things that are smaller and longer in terms of our blood vessel repairs don't tend to last as long. In general, we find that people do better with our open repairs, where we create a new blood vessel, also tends to last a little bit longer than the endovascular repairs, the minimally invasive repairs. Those are really nice to be able to get somebody blood flow back online or fix a blockage and get blood flow now, but it may not last as long. So we try and do repairs for rest pain that will have a lasting impact on somebody's blood flow. And then ulcerations that require inline blood flow to heal, we often need to do a bypass surgery for longer segments. And we also think about a thing called angiosomes, where certain parts of the foot are supplied by different arteries. And so we may choose the artery that we treat, or the blockages that we treat, based off of where the blood flow is going, and trying to bring the blood flow directly to the area that we need. And we may do something called a toe pressure, where we take the pressure at the toe, and that'll give us a quantity of blood flow that's getting to the toe. And that's a nice measure for there is or there isn't enough blood flow to heal. So in the aortoiliac segment, we can do aortobicameral bypass. We can also do common femoral endarterectomies and iliac stenting. And the bigger surgeries tend to be more invasive, but they tend to last better. We can also do them on all different anatomies of blockages, versus sometimes we can't get the stents in the pelvis to cross through the blockages if they're very, very severe. And then here's just a picture of an inguinal bypass, where we can either use a piece of plastic or somebody's own vein to create a new pathway for blood flow to travel from point A to point B. And ideally, somebody's vein is greater than 3 millimeters and on the same side as the surgery, but sometimes we have to use a vein on the other side, or a vein from the arm, or a vein from a cadaver if somebody doesn't have a good vein. Here's just a picture of an endarterectomy, which is another way to treat, especially the blockages that happen at the groin, where we physically pull out the plaque and put a patch on the vessel. And this causes it to, or helps it to not narrow back up again. And so that is most of what I had to talk about for peripheral arterial disease. And I actually think that we are running a little bit lower on time. So I'm going to open things up for questions, and I'm happy to talk about peripheral arterial disease or whatever else people want to know about vascular.
Thank you, Dr. Marecki. That was an amazing presentation. I particularly enjoyed the pictures, the explanations, and even your hand-drawn vascular person was awesome. So thank you again for that. We do have quite a few questions that I'm hoping you can help us understand better. So There's quite a few in the chat that are about signs and symptoms, and I thought this might be best addressed rather than getting into one particular item to put them in a group. So a few of the questions are about, can you differentiate between how do you know when you need to go see someone, such as I have pain when I'm walking, I have pain when I'm standing for periods of time, or I'm getting cramps at night. How do you differentiate that? And who are those questions best identified by in healthcare?
So, I mean, I think that, as I said, it's a commonly misunderstood specialty. We're always happy to see anybody and kind of give our evaluation because we see a lot of these patients. I think that that's a really important point that I didn't mention, that a lot of times people will think, oh, I have cramps in my legs at night, and that causes a lot of pain. Do I need to be worried that that's rest pain? Generally, rest pain occurs in your forefoot, in your toes, and it isn't actually associated with a muscle cramp where you like have a hardening of your muscle. That's much more commonly related to electrolytes or something else, but blood vessel blockages don't tend to cause cramps. They can cause a crampy feeling when you're walking, but they don't actually cause your muscle to cramp up. And then in terms of, you have pain. I think the reason that people when they come to see me is when it gets so bad that they feel like they can't do what they need to do. I like really want to be able to do this. I've been trying to walk as much as I can. I've been trying to keep up with my grandkids, but I just can't walk as far as I want to, or I can't play tennis like I used to. Then I think that's a good reason to, kind of talk to your primary, get referred to a vascular surgeon, and we'll do evaluation, see if there is a component of peripheral arterial disease that may benefit from either conservative or invasive treatment.
Wonderful. The next questions that are coming up are about the role of medications. Specifically, a few questions about how statins and how blood pressure medications prevent the progression of PAD and how they contribute to overall wellness.
Absolutely. So we focus on having a good regimen of these medications to protect against all blood vessel disease in the whole body. Particularly statins work because they downregulate the cycle of inflammation that causes those foamy macrophages to eat the dangerous lipoproteins, so the low density lipoproteins, and so can prevent those plaques from forming and can stabilize those plaques so that they don't get those dangerous edges that can cause plaque ruptures and thrombosis. And so it contributes to having less heart attacks, having less strokes. And so really, peripheral arterial disease is, I love treating it because it affects people's lives, but it doesn't sort of affect how long they live most of the time. And so the reason that, the statins and the blood pressure medications are so important is because we can we can make people live longer. So you may have, noticed you had blood vessel disease because of pain in your legs, vascular claudication, but now it's time to make sure we get on a good regimen of medication so that you can actually live longer.
Thank you so much. Next two questions come regards to lifestyle. So the first question is about how does obesity contribute to PAD? And then is there any lifestyle adjustments that can be made to reduce plaque progression in the human body?
Absolutely. So obesity really acts via the hyperlipidemia and the diabetes, as we understand. And obviously, if you weigh more, it's harder to get active, stay active. and it's more work for your body to do when you do go to move. So in terms of what are the other lifestyle modifications, I actually, don't think that we talked a lot, that I talked much about it, but the one conservative way to treat claudication is actually to walk as much as possible. And so the more exercise that you do, it actually helps. So unlike everything else where you say, oh, this hurts when I do this, and the doctor tells you not to do it, we're actually telling people to do it. So you walk and you get a little bit of pain, just take a few steps further and then take your rest and then do it again. And you'll find that if it's vasculogenic claudication, it will actually get better as you walk more, because your body grows blood vessels in response to you asking for more blood flow. And it's the safest and easiest way to sort of treat vasculogenic claudication, where your body's growing the pathways instead of the vascular surgeon having to create the pathways.
Thank you. That's excellent. This next question, I guess you could provide your expertise in. It's about they have an upcoming first-time vascular appointment and want to know, if I bring an over-the-counter supplement bottle with me, can the doctor tell me if it's a good support for my leg veins in general or more specific, or if I have future diagnostics, or tell me if there's a beneficial supplemental product available. So I guess this question is teed up as, what can I get? How can I get the most out of my first-time vascular doctor appointment from your expertise?
So I think that there are probably a lot of good supplements, but unfortunately, we just don't have good data on a lot of the supplements that aren't sort of FDA approved on the differences that they make. So I do think that there is data that some of the fish oils and the things that are helpful for atherosclerosis may be helpful additionally for vascular disease. I do think that if you always bring your full list of medications to your doctor's appointments, because we'll want to take a close look at kind of which medications you're on and if there's anything that we can tweak about the medications. And then I think the most important thing is for you to just pay attention to your symptoms, so that you can sort of describe your symptoms the best as possible, and we can get a better idea of, is this related to a blood vessel problem? Could it be related to the arteries or the veins? And what steps do we take from there in terms of what diagnostics are appropriate?
I think just time for two more questions. The first one is coming from a few people who are asking about phlebitis. Could you just comment briefly on phlebitis?
Sure. Generally, phlebitis is a term that we use for superficial thrombosis of a vein. So deep venous thrombosis is the ones that people worry about, travel to the lungs and can be life-threatening. Superficial thrombophlebitis is often not dangerous, but very, very painful. For some reason, the nerves and the skin that are much more sensitive. And so if you have a clot that's in close proximity to the skin, the inflammation around it can be pretty severe. We generally tell people to treat it first with NSAIDs and heat. If it starts to feel like it's getting worse or you're getting systemic swelling, you might need an ultrasound to make sure that it hasn't progressed beyond the superficial to the deep system.
One last question. There's so many good questions coming in chat. Thank you for asking them. Unfortunately, we don't have time to answer them all. This last question is about how you differentiate between a vascular problem versus a neurological problem. Can you elaborate just quickly on that?
Yeah. So the relationship of the symptoms to exactly when they happen and the positions in which they happen with. I think getting a really good history on that is how I go about trying to figure out the difference. So people tend to feel better with neurogenic claudication or pain that's due to kind of blockages in the back if they lean on something, if they lean on a railing. Sometimes the neurogenic symptoms are a little bit less consistent. Like you might have them some days, you might not have them some days. You might have it in one leg one day, you might have it in another leg one day. And they might happen as soon as you stand up, versus the vascular symptoms are generally more consistent. They happen always after 2 blocks of walking, or maybe 1 block of walking uphill. And they happen the same way every single time, where like they always happen the right leg first, and then they happen, and then both legs start to feel it. So those are just a little bit of the fine details ways we tell the difference between the two.
Thank you again, Dr. Marecki, and thank you to all of you for joining us this Sunday. We really appreciate your participation. If you're considering financially supporting the future of heart and vascular care at Bay State Health, visit baystatehealth.org/giving for more information. If you'd like to see a recording for the series, visit baystatehealth.org/heart series. Thank you again, everyone, for your participation, and thank you to Dr. Marecki for this wonderful topic. Thank you so much.
My pleasure. Thank you.
Have a wonderful day.